Good afternoon, good evening, good morning to wherever you are on this planet, and a very warm virtual welcome to the ASPA Flex webinar. Am I heard, first of all? I guess I am. Your presence from all over the globe add immense value to this gathering of minds eager to learn. Let's embark on today's session. We continue to unravel the ultrasound in its diversity, and we are going to actually look at it in a very pragmatic, day-to-day, case-by-case manner. Today, we shall start decoding neonatal cranial ultrasound to real-life cardiac implications, which actually can change the course of our case management. Then we shall explore the lung ultrasound intricacies, and we shall demystify certain gastric ultrasound principles and the know-hows of it, which shall actually help us in the most challenging situations where we are always worried about the empty stomach and nil by mouth issues. So today's session surely promises insights that transcends the routine that we have considered till today. So stay tuned also for a special revelation on the postoperative day 2 absent pulsations in the operated lower extremity, followed by another surprise little case, just to tell you that once you have a probe, you can actually pick it up and apply it anywhere, wherever you have a clinical question, and you might be helped with an answer for sure. Without any further ado, from here on, I give this webinar over to Dr. Josephine Tan. She is the senior consultant in KK Children Hospital, Singapore, and she is the immediate past president of the Asian Society of Anesthesiology. She is also the current head of ASPA Education Committee. Well, I guess prior to that, Joe, before Joe really comes in and speaks, I guess I left out myself as the person who's speaking to you. Let me let you all know who I am. I am Dr. Vrushali Ponde. I am the lead. I happen to be the lead of this webinar, so you know who has really made the whole team work. Well, humor apart, I serve the Asian Society of Pediatric Anesthesiology as its president-elect and the SIG, that is Special Interest Group Lead for the POCUS and RA. Well, over to you, Joe.
Hello and good day to everybody. Welcome again to the last ASPA Flex webinar of 2023, focused on POCUS. Before I run through the housekeeping rules and reminders of the webinar, let me first introduce Dr. Serpil Osgan. Dr. Serpil Osgan is our current ASPA president. She's also an associate professor in the Department of Anesthesia and Reanimation in the University of MAA in Istanbul, Turkey. She is a member of the Educational Committee of ASPA and also head of the Scientific Committee of the Peds Anesthesia of Turkish Society of Anesthesiology and Reanimation. And also, I would like to introduce to you Dr. Biba Vari Knight. She's the most important person here today. She is responsible for putting all the IT together to make this webinar possible. Dr. Knight's real job is actually an onco-anesthesiologist and intensivist at the Basvatarakam Indo-American Cancer Hospital and Research Institute in Hyderabad. Now, some housekeeping rules. How can you ask a question during the webinar? The chat and the raise hand functions have been disabled, so you can ask or share your comments through the Q&A section. Our moderators will highlight your questions to the appropriate speaker during the panel. Some of the questions may be answered by text by the appropriate speaker in the Q&A section. A certificate of attendance will also be sent to you. It will be automatically generated and forwarded to those who submitted the post-webinar survey. The post-webinar survey will be emailed to you tomorrow at 5 p.m. Singapore time. Please ensure that you have keyed in your name and your email addresses correctly. Do not worry if you have to miss part of the webinar. The webinar will be recorded and it will be available on our website, on our Facebook, and on the YouTube. For those of you who are attending the webinar, a disclaimer from ASPA, please note that the information presented in this webinar is intended for educational purposes only and is not meant to be a substitute for professional medical advice, diagnosis, or treatment. And the views expressed in this presentation are those of the presenter and do not necessarily reflect the opinions or policies of any institutions or organizations which they are affiliated. Additionally, the information presented may not be applicable to all individuals or situations. So we have gathered under Dr. Broshali many speakers, very renowned speakers around the region in Asia, and we have prepared a very interesting program for you. And without further ado, let me introduce our first speaker. Our first speaker is Dr. Pradip Suryawanshi. His background training is in pediatrics, and he's the professor and head in the Department of Neonatology in Pune. And he is also the director of neonatology and pediatrics in Sahyadri Hospitals in Pune. Let us now welcome Dr. Pradip Suryawanshi. And his talk today is Valuable Cues, Neonatal Cranial Ultrasound.
Good afternoon, friends. Thank you for the Pediatric Asian Society of Anesthesiologists for the opportunity to discuss about this case-based discussion about the POCUS movement. We'll be discussing about an important case from the neonatal unit with the importance of cranial ultrasound. So, this is my city, Pune, which was the capital of India in the 17th century. What we'll cover in the next 15 minutes, we will try to see the role of ultrasound, brain ultrasound, in day-to-day practice, mainly for the infections, which is very common in neonatology. And then I'll just briefly cover about the research components and training component in India, which we are taking forward in the neonatal POCUS. We all know that insonation is the fifth pillar in our day-to-day practice now. That's a basic things which we need to incorporate in our day-to-day practice. The POCUS helps for diagnosis, critical assessment, procedure, therapeutic interventions, mainly for screening and monitoring and prognosis of the neonatal cranial ultrasounds, and which I want to also concentrate on the research. That's what the program, what we submitted, and this is the article we published in the Indian Pediatrics as a point of care ultrasound in neonatology in India, the way forward. The component which we included for that POCUS for the newborn are the cranial ultrasound, cardiac POCUS, lung POCUS, gut POCUS, line POCUS, procedures and research. So let's discuss about this case, which was very interesting, very simple case, but a lot of time we go through those parameters in neonatology. See, this is a full-term baby, normal vaginal delivery, and baby actually admitted in another NICU on day 3 of life because of the tachypnea, where the doctor has started the baby on CPAP. Baby was initially not given milk. After that, baby started the milk, but baby hasn't tolerated the milk, would develop the distension. The clinical features, baby also had abnormal color, abnormal ABG, and the coagulopathy with thrombocytopenia. Naturally, the baby was deteriorating. Hence, the baby was shifted to level 3 in ICU for the purpose of distension, distress, subtle seizures, baby required ventilation, vasopressus management, and started with antibiotics and outbound baby. That's what happens. So you see now these babies' POCUS. This is where we go day to day now. This baby's clinical history is suggestive of definitely late onset sepsis. That's a clear-cut clinical parameters for us. But how my POCUS has changed the thought process, how the POCUS has evolved, and we consider these babies' diagnosis, that's very important. So if you see this baby has, in this coronal view, these are the basically echogenic lesions inside anechoic lesions with a clear-cut boundary of echogenicity. These are the ones you can see serial where we could able to visualize these lesions. If I go to the sagittal view, those lesions are very, very clear-cut. And they are not one lesions, they are 1, 2, 3. Multiple echogenic lesions with inside anechogenicity. So when this happens in us in neonatology, most likely diagnosis for us turns out to be the infection. This could be a brain abscess. If we see the initial part of the color Doppler and grayscale, this baby has echogenic parenchyma with increased blood flow and the Doppler done. This was the anterior cerebral artery done in the sagittal view. This is the normal Doppler. In this baby, the Doppler was showing reversal of flow. And what we done in the research, previous research, what we shows that the babies with suspected sepsis, the reversal of Doppler, naturally they are late onset sepsis with a bad outcome. And that's what the research published in Journal of Neonatology by our team. So this baby has echogenicity, increased blood flow with the lesions with reversal of a Doppler in anterior cerebral artery. Definitely we have utilized the POCUS for lumbar puncture. So that's a spine with color and that's the spine ultrasound. So you can see the needle coming and then that's the useful for avoiding traumatic taps. Ultimately the proteins were high, very low sugars, and the cells were almost 70 polymorphs and lymphocytes. So definitely we are dealing with here late onset sepsis, meningitis. But this is a term baby and the baby was born outside with previous history of admission to the other hospital, we need to think about gram-positive, gram-negative as well as fungal infection. That's a common where we deal with Asian countries as gram-negative and fungal infections are emerging. And fungals are emerging quite a lot. We should be careful. So if you see, to confirm this lesion, MRI done. So these are the multiple lesions which will continue to confirm. And you see the MRI which shows nice multiple. These are the multiple lesions with you can able to visualize as the collections, and that turned out to be a brain abscess in this baby. So that's the importance of the POCUS in this brain. Side by side, we have done the cardiac POCUS in this baby, and that cardiac POCUS shows this significant TRZ. That's a marker of secondary pulmonary hypertension. So the babies with the late onset sepsis in India, they do present with the secondary pulmonary hypertension. That's one of the research our team has published in Journal of Ultrasound. We also have documented this baby's PDA, which was reopened, and this is a bidirectional PDA. So this is another marker of pulmonary hypertension. So that's one more research done by our team, which shows that late onset sepsis in India has secondary pulmonary hypertension. You could able to diagnose by the TRZ, or you could able to see by this bidirectional PDA, and that's the very useful component. So there is a hypotension, there is a secondary pulmonary hypertension. At the same time, we have measured the velocities at the aorta and pulmonary, and those velocities were very high, which are indicative of high cardiac output. So these babies with a late onset sepsis has a high cardiac output. Pulmonary hypertension, high cardiac output associated with hypotension. What ultimately we know or physiologically that these babies' hypotension is because of the ACVR. So in neonatology, lot of these hypotensions are warm shocks, they are vasodilatory shock. So this is what the POCUS has enhanced me. Brain diagnosis with the cardiac POCUS support to find out the cause of hypotension to select the vasopressors, which most likely here is a noradrenaline or adrenaline. That is a better vasopressors when we consider. At the same time, these babies have a ventricular dysfunctions. So this is one more research published by our team is that late onset sepsis in the later stages have a biventricular dysfunction. And that's very useful to document. At the same time, you could see this baby has a mild to moderate pericardial effusion, mild, you can see the moderate pleural effusion and ascites. So multiple organs involved with these babies have a collection of the fluid, which is because of the third space loss. And this is pretty common in India, where we do see that hypotension with vasodilatory shock with third space loss. So what we documented that the septic shock in India has secondary pulmonary hypertension, has hypotension with high cardiac output, with vasodilatory shock, with biventricular dysfunction, with third space loss. And this chart is useful for management of these babies. Also, the POCUS has helped in confirmation of endotracheal tube because this baby required intubation. This baby's PIC line also useful by the POCUS as a multiple things we could able to see, and that's advantage for these babies to confirm the line position. So we saw the brain ultrasound useful, we saw the cardiac ultrasound useful, we saw the lines also useful when there is a single case, and that happens. After 4 days, the culture came as a candida. I said gram-negative sepsis and candida, they are now the big culprits in India rather than gram-positive infections. So we have big issues in India. We have to be very careful about the use of antibiotics and the flora where the candida infections are going up. So think about that. We have done one more research and we documented that late onset neonatal sepsis has brain abnormality around 45%, cardiac abnormality around 84%, lungs around 28%, abdomen 10%. So friends, we need to document this research also, and that is going to help us for the management of our patients. So other important role of the POCUS brain, just to have a summary, we saw now this case, but the POCUS is useful. See now in the brain, this is nothing but the subdural collection. So this is subdural empyema. This baby's blood culture came positive as E. coli. This is another baby with a dilated ventricles inside septations. This is nothing but ventriculitis with gram-negative sepsis, and culture came out to the Klebsiella. So that's a very useful immediate diagnosis. This is the baby with tortuous group of infection, dilatation of ventricle, and calcification. So this is nothing but the CMV, congenital CMV, which is useful to diagnose immediately. Naturally, I told you the POCUS is very useful in preterm babies for monitoring of the bleeds. So see this one, great blood bleed in the ventricles, not dilated, around less than 50% blood in the ventricles, more than 50% blood in the ventricles, and the blood going outside the ventricles. These are the ones which we can consider as screening purposes for IVH. One of the common causes of India is asphyxia, and where you could able to visualize these echogenic term babies with hypoxia, and day 2, day 3, you will be able to see this wonderful echogenic. This is the thalamus echogenic. This is the basal ganglion echogenic, and we call this as a 4-column sign. 1, 2, 3, 4. And you can see this anechoic lesions or prominent. We call this as a prominent or visualization of internal capsule. Ideally, you can't identify an ultrasound internal capsule. This is a bad sign asphyxia. So this is nothing but HI3. This is what the sagittal view, thalamus visualization, basal ganglion visualization, and this is the anechoic visualization of the internal capsule. So that's how we could able to identify. This is a 26-weeker baby at 6 weeks, cystic lesions in the brain. This is nothing but the PVL. So these are the advantage of the cranial ultrasound, where we could able to identify infections, bleed, hypoxia, PVL, which are very common in neonatology, which changes your management, which changes your prognosis, very useful for counseling. Friends, one more thing which I want to trace is the research and training. That should go hand in hand when we consider about these parameters and when we consider about the POCUS. So far, so we have published almost 30 original articles related to the POCUS, and we started a lot of trainings. These are the books written by our team related to the neonatal POCUS. These are the book chapters in various books written by our team related to the POCUS and the cardiac hemodynamics. These are the international guidelines published last year. POCUS protocol when the baby crashes. What component we included? We included the lung, cardiac, abdominal, and cranial. So when the baby crashes, cranial POCUS is for mainly bleeding. Check that baby has crashed because of the bleed, which could be intracranial or intraventricular. And that's what the international guidelines which I represented Asia, and that's very important role of cranial POCUS. For training purposes, friends, we started this new concept called as Neo POCUS in the COVID times since last 4 years as a 6 months programs to train the neonatologists of the world, which includes all components of the POCUS. And we have members from 18 countries. We have trained so far 400 members from 18 countries in the world. These are the 6 batches. So far, so we have conducted. These are the 4 batches. These are the 2 additional batches. That's batch 6, which is going on currently. And that is what happening, friends. So what we would like to conclude here, friend, neonatal POCUS is a future in neonatology. I have already given importance of the neonatal cranial ultrasound. Very easy, very simple, bedside. Immediately it will finish in 1 minute. You can diagnose, you can prognosticate, you can able to counsel the relatives. Hence, neonatal cranial ultrasound is mandatory for all neonatologists. This is the one which I told you that POCUS in India the way forward, and we all believe that the portable ultrasound is the future stethoscope in the 21st century. And we all should learn this one. We all should implement in our day-to-day practice. Thank you, friends.
Thank you, Dr. Pradip, for that very interesting talk. Our second speaker is from Korea, and Dr. Jin-tae Kim, and his talk today is on how my knowledge of cardiac POCUS saved my day. Dr. Jin-tae Kim is a Chief of Department of Pediatric Anesthesiology and Pain Medicine in Seoul National University Children's Hospital in Korea, and he's a full professor in Seoul National University Hospital, College of Medicine, South Korea, and he's also the president of the Korean Society of Pediatric Anesthesia. Just give us a few moments. Dr. Kim will be sharing slides of his video.
In today's presentation, I will discussing cardiac POCUS, specifically talking how to find cause of hemodynamic instability and manage it. I'm Jin-taek Kim from South Korea. I have no conflict of interest regarding this talk. When do you usually perform cardiac POCUS? Probably most of you perform cardiac POCUS when patients' vital signs are unstable. In my practice, I typically perform the echo when I expect the patient hemodynamics deteriorated before or during induction of anesthesia, especially when preoperative echocardiographic data are not available. During surgery, cardiac POCUS frequently utilized when hemodynamics are unstable, with a common scenario being the occurrence of a hypertension. Blood pressure is determined cardiac output and systemic vascular resistance, and cardiac output is determined preload, afload, and contractility. So finding cause of low blood pressure and treat appropriately is very important. When considering cases where ROSC does not occur after cardiac arrest, it is worthwhile to contemplate these possibilities. Performing echocardiography with these considerations in mind can be beneficial. During operation, when patient hemodynamics are unstable, we need to ask ourselves 5 questions. How about the intravascular volume, preload? And is it okay cardiac function, contractility? And how about the afterload and vascular resistance? And we need to check presence of any intracardiac abnormality, for example, valve and other cardiac abnormality. And then lastly, we should ask if there is okay and extracardiac problem, such as pulmonary embolism, tamponade, and pleural effusion. For the POCUS, for the transthoracic echo, we need to apply the probe. We have a basic 5 view, a subcostural 4-chamber view, apical 4-chamber view, and parasternal long axis view and parasternal LV short axis view, and pleural scanning also important. And also we can use a transphageal echo, and basically it is very similar to transthoracic echo. I'd like to mention in advance that both TEE and TTE image will be utilized in my presentation. Let me elaborate a bit more on short axis image. This is a TEE image, transgastric medial esophageal short axis view. And the short axis image is extremely useful for assessing the overall function of the ventricle. Additionally, it aids in identifying the coronary artery territory. When evaluating ventricle, it is essential to always consider the volume status, cardiac contractility, and systemic vascular resistance. Short axis image shows end diastolic volume and systolic volume, so it is very useful. If you look at this 4 image, you can see that this image is normal short axis image. It's a preserved cardiac function and contractility and well-preserved end diastolic volume and systolic volume. And this image shows that there is some problem of the coronary territory where there is a regional wall motion abnormality. If you look at this image, you can see that the very increased end diastolic volume and systolic volume you can easily identify there is some contractility problem. And if you look at this image, you can identify very decreased and systolic volume and diastolic volume. So you can see that this image shows that the patient might have a inadequate volume status. Identifying the cause of low blood pressure is crucial. To simplify, in case of left ventricular dysfunction, both the left ventricle end-diastolic area and the left ventricle end-systolic area is increased, and then the fractional area change decreased. On the other end, in hypovolemia, both left end-diastolic area and the left end-systolic area decrease. If there is a decrease in the systemic vascular resistance, LV end diastolic area is not show significant change, but the LV end systolic area tend to decrease. Finding the cause of hypertension is crucial for appropriate treatment. If the left ventricle dysfunction detected, then we can give inotropic. If the patient has the hypovolemia, we should give a volume. And if patient has low systemic vascular resistance, then we can give a vasoconstrictor to the patient. Can you identify the difference between the two images? One represents hypovolemia, while the other is the case of low systemic vascular resistance. Please take a look at both LV and the systolic area and LV and diastolic area. In the hypovolemic case, on the right side, both LV and the systolic area and the LV and diastolic area are decreased. In the left image, with the low systemic vascular resistance, LV and diastolic area is relatively maintained. In such case, using a vasoconstrictor may be more beneficial. Let's examine the case. The patient is 12 years old with a mitochondrial disease, scheduled for implantation of pacemaker, and a patient received norepinephrine and epinephrine infusion and the septic condition. The patient manifests hypotension. If you look at these two images, you can see that LV and systolic area is quite decreased. But the patient LV and diastolic area is relatively well maintained. So we think this patient might have some problem of the systemic vascular resistance. And this patient shows a contractility. Let's move on to the next case. 34 months of age, blood pressure is low. And if you look at this vital sign, it is very difficult to why the blood pressure is decreased in this patient. But if you look at this image, you can easily identify why this patient shows the hypertension, cardiac tamponade, of course. Next case is about 17-year-old female patient who had undergone the Kasai procedure for biliary atresia. She was scheduled for exploratomy and intraoperative endoscopy. While intraoperative endoscopy is performing, a cardiovascular collapse occurred. She immediately after discovery of ulcerative reason entered the CO2 abruptly decreased from 30 to 70 millimeter mercury, and severe bradycardia occurred within a few seconds. At the event, the EKGs looked like this, and we performed cardiopulmonary resuscitation, and she recovered. But we could not make a definite diagnosis in this case. So we inserted transesophageal echocardiography probe. We could inserted transesophageal echo probe about 30 minutes after the event, and air bubble were observed in both ventricle, in the aorta and pulmonary artery. So we think that this event is due to the venous embolism. Although number of bubble decreased gradually, bubble were continuously observed for 1 hour in the pulmonary vein, left atrium, and the left ventricle. This case demonstrates that the intraoperative echo can play an important role in diagnosing and managing an embolism in anesthetized patient. Let's move on to the next case. This case is interesting. 4-year-old child who was scheduled to receive the cranioplasty, and then the outer line and the central venous catheter was inserted. Central venous catheter was inserted in the right subclavian vein. Intraoperative hypotension detected, but it was refractory to the volume resuscitation and inotropic administered through the central venous catheter. Only inotropic administered through the peripheral line was effective, and patient saturation also decreased. Why this patient developed hypotension, and what is the reason? We applied cardiac POCUS, and we found that the relative hypovolemic condition, but importantly, at the pleural space, we found that a huge amount of pleural effusion and the blood clot. And this was pleural effusion mixed with the fluid and blood that we administered through the central venous catheter. And we checked the chest X-ray, and then we insert the chest tube, and then we identified the central line that was inserted to the right subclavian vein. The tip was in the pleural space. Last case is about 19-year-old female patient who received Hickman catheter insertion. I was called when the patient arrived in PACU because of low saturation. I reviewed the patient intraoperative data, and I identified the increased heart rate and decreased blood pressure intraoperatively. I think about why the blood pressure decreased and why patient complain of low saturation in the PACU. So I applied the cardiac probe to the heart, and we found that the relatively hypovolemic condition. We also found that there is a huge amount of the effusion and the pleural space, and there is some clot. I checked the Hickman catheter location, but it is okay. And then we also applied the lung echo and the lung ultrasound, and then we insert the chest tube for the management of this patient. In summary, during my presentation, we have reviewed cases where cardiac POCUS has been useful. Cardiac POCUS is highly beneficial for managing patients during anesthesia. The reason for this is that it provides variable information about cause of hemodynamic instability. When blood pressure drops, it helps in determining why blood pressure decreased. Accordingly, it is helpful in determining to prioritize fluid administration, inotropic, or vasoconstrictor. Fluid administration for hypovolemia, inotropic for cardiac dysfunction, and vasoconstrictor for low systemic vascular resonance. Please remember LV and diastolic area and LV and systolic area while performing cardiac POCUS. Additionally, it proved helpful in diagnosing challenging situations. Sometimes patients have some problem in extracardiac condition like hemothorax, embolism, or cardiac tamponade, and etc. Patient might have some intracardiac problem like a SAM, valvular dysfunction, and LVOT obstruction. So if we effectively utilize cardiac POCUS, I believe that we can successfully manage hemodynamically unstable patients. thereby improving patient outcome and enhancing the overall quality of our medical care. Thank you for your attention.
Thank you, Dr. Kim. Well, let's introduce the next speaker. Let me present you Dr. Chor. He is a pediatric intensivist. Sarawak General Hospital is the place where he works, and point of care ultrasound and renal transplant therapy are his special interest. Over to you.
Good day, my name is Chor Ki, pediatric intensivist from Sarawak General Hospital, Malaysia. Today, I'm going to share with you how I use point of care ultrasound of the lung in my day-to-day practice. I'm going to share with you 10 different cases for the purpose. Point of care ultrasound of the lung is very useful. You can assess the severity, location, characteristic, and progression of the lung disease. These are the 5 important different lung conditions that can be diagnosed using point of care ultrasound. Number 1, the Ehrlich syndrome. Number 2, pulmonary edema. Number 3, lung inflammation, be it a pneumonia and ARDS. Number 4, pleural effusions. And lastly, lung mass. Let's go to case number 1. This is a 1-month-old baby presented with fever for 1 week with neck swelling. And he have a necrosis and abscesses around the neck area, as you could see here. This child have disseminated streptococcus infection, and the exploratory of the neck was done in the theater, showing that abscesses, collections, and necrotizing lesions around the neck and extended to mediastinum. Unfortunately, intraoperatively, the child noted to have acute desaturation with bilateral hyperinflated lung. Point of care ultrasound was performed and showing this finding. So this is a normal lung ultrasound. We show that this is a rib, and then this is a pleural line, show the sliding of the pleural line, suggestive of presence of the lung. This is a finding of the patients, which is the right side, this is the left side. You show that there is absence of the lung sliding in this both lung field. This suggests that the child have bilateral pneumothorax, and the chest drain was inserted. The child condition improved immediately after the chest drain insertion. This shows us that the importance of point of care ultrasound in urgent diagnosis of pneumothorax. This is an X-ray of the child showing that there's 2 chest drain inserted, okay, and the chest drain was consistently bubbling. Beside that, from the X-ray, you could see that there is significant subcutaneous emphysema of the both lung field. And what else can you conclude from the X-ray or maybe the ultrasound? Besides telling us there's a presence or absence of pneumothorax, point of care ultrasound could also assist us to assess the extensions of the pneumothorax, as we could clearly demonstrated in this point of care ultrasound corresponding to the CT scan finding. When the probe is putting anteriorly, this view suggests of significant pneumothorax. When the probe put in laterally, we show that there is lung point that are present here. The lung point is the border between the normal lung and also the area of the collection of the pneumothorax. And at the base wise, you could see that the significant consolidation, which is corresponding to the CT scan finding here, and a relatively normal lung field, whereby there is no air collection in this pleural cavity in this particular area. It shows that the point of care ultrasound not only tells us the diagnosis of the pneumothorax, but it also assists us to look at the extension of the pneumothorax to which area the lung is having pneumothorax. And this is very useful to assist us in terms of the subsequent treatment strategy. Case number 2, where this 4-month-old child with underlying Down syndrome have recurrent pneumonia admitted for respiratory distress. You have the X-ray here. Right? The registrar will ask you, should I put in a chest drain in this child as he suspects pneumothorax? So the question is quite tough looking at this X-ray. So the point of care ultrasound can easily solve your questions. And you could see here, this is a lung ultrasound on the right side. We show you that some pleural line, okay, this is moving with some B line, and the corresponding area that we are worried of pneumothorax show that there is no pneumothorax in that particular area. There is still presence of lung in here, in this area. And it tells us that this child is not having a pneumothorax, probably have a large bullae. And this is a corresponding CT scan of the child with presence of significantly huge bullae of the left lower lobe. Case number 3. We have this 6-year-old boy who had perforated appendix. He had extensive free resuscitation pre-op and intubated in OT for exploratory laparotomy. The anesthetist noticed that the child needing increasing ventilator support. So what happened to the child now? Is the child have ARDS, pneumonia, or a pulmonary edema? A bedside point of care ultrasound showed this finding with presence of acute pulmonary edema. It can be easily performed at the bedside and letting the clinician know that what has happened to the child that require increasing ventilator support. And this will assist the anesthetist in terms of treatment by giving a diuretics, and the child condition will improve. This is a typical finding of the lung ultrasound in the patient with acute pulmonary edema in a different severity. So it is a normal lung ultrasound, and this is a lung ultrasound with mild pulmonary edema, which we see that there is some line coming down from the pleural line, in which we call a B line. When the B line increase in terms of the number, suggestive increasing pulmonary edema, and if the B line become confluence, suggestive of severe pulmonary edema. This kind of pattern is quite similar to the rain pattern. So if you have a few drop of rain, which is like similarly with this few drop of B line, suggests the mild water content. When the raindrop become more like this pattern, it's suggestive for increasing water content, and also which suggestive for increasing severity of pulmonary edema. Case number 4. We have this 7-month-old baby with complex cyanotic heart disease, dextrocardia. He had post BT shunt 1 month ago, presented with tachypnea and grunting. From the chest X-ray point of view, the registrar would ask you, should I give Lasix to dry out the lung? The point of care ultrasound will tell you otherwise. So this is a point of care ultrasound done in these patients, which show that this child actually have huge pleural effusion with a collapsed lung. And not only that, it tells you the consistency of the fluid, which suggestive of some particle inside the fluid and suggestive of exudative pleural effusion. Fair enough, when the chest drain was inserted, right, this child had actually a chylothorax, and this is a chest X-ray post-drain removal, which show that the lung fluid actually clear out and the child improved without needing any fusimide. Point of care ultrasound not only tell you the presence of the pleural effusion, but it also can assist you in terms of quantify the volume. So this is a mild pleural effusion, moderate, severe pleural effusions, and massive pleural effusion. You also can tell you the consistency of the fluid content. As you could see here, this is a clear fluid, this is a fluid with some fibrin, a more exudative fluid, and organized empyema. So this is a classical image of point of care ultrasound in terms of lung consolidations, right? So this is a small little patch, as you could see here, right, which is corresponding to the pathological finding here. So when the lesion is become increased in size like this pathological finding, will be able to shown on the ultrasound. And if the whole lung is consolidated, right, it actually can be easily and readily seen using point of care ultrasound. Not only that, the point of care ultrasound, besides telling you the intensity, it also tells you the exact locations of the consolidation in which chest X-ray will not able to tell you. So this is case number 5. It's a 3-year-old child presented with fever, cough for 2 weeks, poor oral intake, and chest X-ray show clearly a consolidation changes over the left lung field. The question is always that, how long should I treat the antibiotic for this child? Point of care ultrasound sometimes will tell you the additional things that chest X-ray will not able to tell you. So this is a point of care ultrasound of the patients. It shows that significant consolidation, and not only that, the lung ultrasound here shows some liquefied area suggestive of necrosis, right? So this child have necrotizing pneumonia, which can be easily picked up with the lung ultrasound. With this finding, the clinician will need to decide this child will require a longer duration of antibiotic for the necrotizing pneumonia. You have a bad night call to attending these 3 different patients at 6 years old, presented with respiratory distress with a similar chest X-ray finding. Clinical examination shows stony dullness, reduced air entry, and what you should do for the child. Should we put in the chest drain for all these child? So the thing that chest X-ray sometimes very difficult to tell you whether is there a fluid collection or what are the underlying pathology. But point of care ultrasound will come into assist to help you to differentiate all those. Let's look at the first chest X-ray. Right, this is the first chest X-ray. The corresponding ultrasound finding is here. The sound ultrasound will show you that the child has significant consolidations, and what the child needs will be antibiotics and non-invasive ventilator to improve the child condition. This is the ultrasound finding for this corresponding X-ray, which show that this child had massive right pleural effusion with some fibrin suggestive of infective in origin. So by putting a chest drain with antibiotics, the child will improve with the treatment. For this corresponding ultrasound finding for this X-ray show that there's a multi-septations, right, with cystic and solid component. This child will need an urgent surgical referral because he have a significant huge right hemithorax teratoma. So this is how ultrasound, point of care ultrasound can help you in the day-to-day practice to determine what is the opacity in the lung is, whether it is a consolidation, fluid, or the mass. Case number 9. We are 11 years old boy with chronic rheumatic heart disease with ruptured chordae. He presented with severe respiratory failure and hemoptysis and undergone an emergency mitral valve repair. Post-operatively unable to maintain saturation. So this is the X-ray of this child post-operatively. This child showed that the significant opacity of the right lung field, right, and also cardiomegaly. This child has severe ARDS or right lung consolidations or significant massive right pleural effusion. So the X-ray couldn't tell. Lung ultrasound will give you some clue. So the point of care ultrasound showed that the significant collapses over the right lung field. There's no air bronchogram shown here. Similarly, the upper images, right, show you that significant collapse over the lung with prominent vessel as you could see here, and there's no air bronchogram here, suggestive of consolidation. So with the background history of hemoptysis and total right lung collapse, one would think that the Poppy clots that occluded the right main bronchus. So the bronchoscopy was done, showed that a blood clot obstructed the right main bronchus, you could see in this picture. So these huge right blood clots from the previous hemoptysis had occluded the right main bronchus, right, causing the right lung collapse. The right lung collapse can be easily shown in the point of care ultrasound. So this is a before clot removal showing that collapse over the right lung. After the clot was removed, immediately you could see that the lung become well aerated now. And this is the corresponding X-ray as well. Significant right opacity and well aerated lung after the clot removal. As you could see these pictures again, right, the different stages of consolidation that you can demonstrate it in the lung ultrasound. So that carry an important weightage in terms of recruitment strategy. So when we talk about recruitment strategy, we'll try to find out what is the best pressure in order to aerate the lung. Okay, so the lung ultrasound finding can tell you at which stages the lung is at the different stages of pressure, as you could see in this diagram. Case number 10, I'm going to show you how point of care ultrasound can assist in terms of lung recruitment. First of all, from this chest X-ray, you couldn't tell you where is the lesion is predominantly. Point of care ultrasound show us that the consolidation is predominantly at posterior area. So hence the child was nurse prone in order to improve the aeration of the posterior area. And child was put on high frequency to recruit the lung as he couldn't maintain saturation very well. Point of care ultrasound was performed as the child was prone. So it was performed posteriorly. So the probe was put in on the spine, okay, located on top of the spine. So this is the spine area of the patient. This is corresponding to the spine area. And this is the lung area here, So this is the corresponding lung area, okay, and with the rib or the corresponding area. As you could see that with the mean airway pressure 18, there's still significant consolidations over this posterior aspect of the lung. And you could see that how high frequency shake the lung from these images. Right? So this was done at 10:32 a.m. So by recruitment strategy, we increased the MAP to 26, right? And from 10:32 a.m. to 10:34 a.m., you could see that significant aeration occurred. This is a consolidated lung, and you could see that the consolidation has significantly reduced in terms of the quantity. This is just after 3 minutes. and then the changes can be easily demonstrated in ultrasound. So 10 minutes later, you could see that more and more lung become aerations. 30 minutes later, most of the lung are being aerated, and within 1 hour time, the posterior consolidation has been well aerated. This shows us that point of care ultrasound can assist in terms of the lung recruitment by showing us the recruitment processes. To sum up, I show you the 10 different patients that how I use point of care ultrasound in the day-to-day practice. Point of care ultrasound actually can assist the clinician to confirm their clinical finding promptly and allow treatment to be instituted and monitored at the same time. And it is relatively easy skill to obtain. I hope that this one will spark some interest among you. Explore the point of care ultrasound in your clinical practice. With that, I thank you for your attention.
Thank you, Dr. Chor, for your very comprehensive talk. I think our audience will have lots of questions to ask you and the other speakers. We are waiting the questions at the question and A section. Now, we would like to introduce you Dr. Çiğdem Tütüncü. She will make her talk about deciphering dilemmas in routine use of gastric ultrasound. And Dr. Çiğdem is a professor at Istanbul University Hospital. Floor is yours.
Hello, everyone. It's a great honor to take part in ASPA Flex webinar. Today, I would like to talk about deciphering dilemma in routine use of gastric ultrasound. I have no conflict of interest. I want to start with a case. We have 10-year-old boy who had diagnosed testicular torsion and an emergency surgery was planned. There was no problem in his medical history and physical examination. His laboratory values were in normal limits, but he drank 2 glasses of juice and ate biscuit 2 hours ago. We decided to perform the gastric ultrasound to establish whether the stomach full or empty. You can see the gastric ultrasound image of the patient, and I would like to ask to you, based on this ultrasound image, what would you prefer for anesthesia management? Let's try to answer this question. But first, I want to ask, why do we do gastric POCUS ultrasound? Why is important? Because the pulmonary aspiration of gastric content is major anesthetic-related complication, which may result in significant mortality. Gastric ultrasound is simple, fast, and non-invasive method that provides us qualitative and quantitative assessment of gastric content and indirectly the risk for perioperative aspiration. And I want to underline, even in elective surgeries, the incidence of full stomach at time of induction of anesthesia varies between 3.5 to 5%. The much higher rates for full stomach are described in emergency surgery, varying between 18 to 56%. Now let's move on to the steps of the gastric ultrasound. We have 4 steps. First step is indication. We need a question for clinical decision whether the stomach empty or not. Second step is acquisition. We should choose an appropriate probe and should scan the patient in an accurate position, then define the sonoanatomy to choose the correct gastric image. Third step is interpretation to define the content. Final step is diagnosis and the clinical decision. Let's look which part of stomach should be scanned, which part of stomach is suitable for ultrasound. Gastric antrum, the most suitable for the ultrasound because the antrum is the most distal part of stomach. Antrum is located in epigastric region, which provides an easily accessible soft tissue window for scanning. And it contains the least amount of air that blocks ultrasound beam penetration as compared to other part of stomach. The other question is, in which position the gastric ultrasound should be performed? The patients should be examined in both supine and heraldic position. The supine gastric exam is qualitative and must be accompanied by examining in the heraldic position, which is most sensitive at measuring gastric volume. Finally, correct probe should be used. Low-frequency curvilinear probe is required for children more than 40 kilograms, and high-frequency linear probe should be used less than 40 kilograms. Now, I want to give some details about gastric sonoanatomy. The antrum is located inferior left lobe of the liver. The liver is used an acoustic window to scan, and it is an important landmark to identify the stomach. The antrum is the first hollow, viscous, distal to the lower edge of the liver. The probe should be scanned right under to the patient's sternum in the epigastric area in sagittal or parasagittal plane. Now I want to show you the common gastric ultrasound images. 3 types of gastric content images can be defined, including no content, fluid, and solids. If you look at the empty antrum, optimal imaging of the antrum includes visualization of the lower edge of the liver at the level of the aorta or IVC in long axis as a small, thin target or round bullseye shaped structure with no peristaltitis. The key sonographic landmark is left liver lobe and its inferior margin at the level of aorta or IVC. Fluid content in the stomach appears anechoic to hypoechoic appearance with larger antrum and thin muscular wall. And you can detect the first gastric peristaltism. Multiple air bubbles can be seen the anechoic background, and it's called starinite appearance, which is typical image for fluid content. If you look at the solid content appearance, antrum will be white, distended, and have a thin muscular wall with slow gastric peristaltism. Soon after a solid intake, we can see frosted gland appearance resulted of the ultrasound interface between air, liquid, and the solids. After a variable period, the content will appear heterogeneous mixed echogeneity. I want to underline the importance of the RLD position. As you can see from the slide, the antrum diameter is wider in RLD position, the diameter, than in the supine position, because the greater proportion of content moves towards the more dependent antrum, and with gravity in RLD position, the sensitivity of the scan increase, and it is possible to detect small amounts of fluid. After the content description in both positions, you should determine the aspiration risk. A semi-quantitative 3-point grading system can help us screening and identifying of the aspiration risk. As you can see, grade 0 is an empty antrum. There is no fluid content in both positions. Grade 1 antrum is an empty antrum viewed in supine, but clear fluids become visible in the RLD position, and the gastric content should be less than 1.2 to 1.5 per milliliter kilogram. Grade 0 and grade 1 represent low aspiration risk. Grade 2 antrum, when clear fluid is detected in both supine and the RLD position with more than 1.2 to 1.45 milliliter per kilogram gastric volume, or solid content with heterogeneous hyperechoic mixed image in ultrasound, and always grade 2 represent high pulmonary aspiration risk. If we summarize the whole steps, first step, describe the content in both positions. Second step, if you find the clear fluid in the RLD position, you should perform the grading. Measure the cross-sectional area and calculate the estimated gastric volume. Finally, we are able to make a decision according to qualitative and quantitative ultrasound assessment of the stomach, and this will allow to us to predict the risk of perioperative aspiration. That the gastric focus ultrasound provides us the valuable information to determine the optimal timing of surgery, type of anesthesia, and airway management technique. Now, I want to go back to our case. We had decided to perform gastric ultrasound. We placed the linear probe perpendicular to the skin, sweeping from the costal margin, seeking the key sonography landmarks, aorta, IVC, and inferior margin of the left lobe liver to show the short axis of antrum. And for the image optimization, you may need tilting the probe anterior, posterior, or caudal cephalad. This is our video in supine position and antrum image in RLD position. You can see the sternite appearance and the first gastric contraction, which is typical and fluid content. Now, I want to give some tips for scanning. Landmarks should always be determined left liver lobe, aorta, or IVC. Focus should be on the lower end of the liver left lobe. Gastric antrum should be viewed in both supine and right lateral positions. Antral cross-sectional measurements should be made in the RLD position when there is no antrum contraction at the level of aorta with repeated measurements. Content classification should be based on 1.2 to 1.5 milliliter per kilogram according to total body weight. As a final step, the gastric volume assessment should be done. Several authors have studied the mathematical correlation between gastric antral cross-sectional area and the total gastric volume. The majority of the reporting found a linear correlation, and this linear correlation exists in RLD position. There are two different ways to measure the gastric volume. You can use the diameters, then calculate the cross-sectional area, then put the cross-sectional area to the formula, or you can directly measure the antral area with the ultrasound and then put the formula, this finding. And you can see the most common used formula in this slide. We use both calculation, and according to the formulation, the patient had full stomach. We decided to perform spinal anesthesia as the patient needs an emergency surgery and had high risk for aspiration. And thank you for listening.
Thank you, Dr. Chidam, for your very nice talk. I think we'll reply the questions afterwards. Now I want to introduce Dr. Vushali Ponde, who is our lead at this webinar. Stage is yours, Dr. Vushali.
Welcome. Welcome to certain out-of-the-box applications, as it were, and let's leverage on POCUS as much as we can. Anyway, prior to that, let's call upon the faculty of imagination. Imagine that we are on an escalator generation which is blessed with a lot of technology, and it just comes to a grinding halt with shoals. We have certain options. We get irritated and we call for help. Either we call for help or we help ourselves. These are the two options we have. And obviously, this is very, very easy to help ourselves here. And that's exactly what happens when you understand POCUS to an extent. You understand the technology of ultrasound and you understand scanning to an extent that it almost becomes your second nature. Let's share certain cases with you and ponder upon what else we could do with ultrasound. Akash, here, he is a 10-year-old, 20-kilogram boy, a case of hereditary multiple exostosis with shortening of right lower limb. Posted for limb lengthening procedure in stages. He suffered from COVID-19 2 months before the operation, and pre-operatively, he and his family were tested RT-PCR negative. So needless to say, this case was done way back when COVID had subsided and we embarked upon our routine work. Well, so he was scheduled for an Alizarov external fixator procedure of limb lengthening involving femoral and tibial osteotomies. Well, the moment we hear femoral osteotomies, we do hear, something in us tells us about the compartment syndrome. We definitely, our antennas are raised out there. But however, we did think of an epidural and we did give it. So GA along with continuous epidural block was given because this is an extremely invasive procedure and is accompanied by intense post-operative pain. Surgical duration was as much as 8 hours and epidural analgesia was administered using 0.2% ropivacaine 3 ml per hour through an elastomeric pump. So the story of day one is as follows. The foot was pale and calming with absent pulses and decrease in capillary refill time. The popliteal pulse was feeble but palpable and there was no tightness in calf. The VAS score was pretty acceptable. So there is a clinically effective pain management which is going on with an epidural analgesia. The foot ring of ankle equinus correction was loosened. As a result, the color improved because the stretching reduced. After discussion, the epidural infusion was temporarily halted because, yes, we all thought that we shouldn't be missing a compartment syndrome here because there is no pain and all this is happening. Anyways, so the differential diagnosis was compartment syndrome and thrombosis. Actually, thrombosis is very rare in children, but we had a history of COVID that made this a possible thought. A review after 2 hours told us this. The foot exhibited improved warmth and was less pale. The popliteal pulsations remained absent. Reinitiation of epidural had to be done because the pain was disproportionate to the postoperative pain expected. Child as well as the family was extremely agitated because just a couple of hours back, the kid was absolutely pain-free. Well, additionally, there was a swelling in the calf and tenderness and stretch pain, and the limb was elevated. That gave us a window to do ultrasound of the popliteal vessels and generally the extremity. However, the rings and the plates around gave us very little window to do a proper ultrasound. The Doppler revealed absent pulsations in the popliteal artery and the color flow was absolutely absent. And this was compared to the contralateral lower extremity showing the difference. Superficial venous thrombosis was also documented. However, let me just confess it to you that it was not one of the best examinations, but enough to know that the popliteal artery of the affected limb was quiet. So this is the non-operative limb, and I would urge you to really see the pulsations which are seen here. And here is the operated limb with absolutely no pulsations. I wish I had the color flow to show you. It would have been even more better. So from the limited windows of ultrasound examinations, we were now in the DSA lab, which revealed thrombus and embolectomy was undertaken. Before the embolectomy, 200 international units of heparin was administered. The thrombus was identified in the superficial femoral artery and the embolectomy was performed under general anesthesia and an epidural. Additional international units of heparin were given during the procedure. Now, it was converted to lower molecular weight heparin in the PICU on day 2. An epidural catheter remained in situ, along with an ongoing infusion of ropivacaine 0.2%, 3 ml per hour, effectively controlling postoperative pain. Now let's fast forward to day 4. On postoperative day 4, the epidural infusion was discontinued. The patient was transitioned to intravenous paracetamol for pain management, and 0.2 ml, that is 20 milligrams of clexane, continued. The epidural catheter was removed after 24 hours from the last dose of clexane. And of course, we made sure that the post-coagulation profile was normal before we pulled out the epidural catheter. So this was a mixed situation where we had to manage the epidural catheter with the ongoing anticoagulation as well. So all in all, this made a very interesting case with a happy ending. Well, there was another case in the wards. We couldn't pull out the Foley's catheter because the balloon could not get deflated. So I asked them to get the patient to the operation theater under sedation. A percutaneous deflation of the balloon was done, and then we pulled out the Foley's catheter. So you never know where you can actually get to use your ultrasound probe. And if it becomes your second nature, the applications can be anywhere. So the take-home message is as follows. Knowledge of ultrasound, a clinical question, combination of ultrasound with the clinical question. It could alter the course of treatment, or it can give you a treatment. So thank you so much. And POCUS is not bogus is something that I would really say. And please watch out for SIG POCUS and RA, which is just around the corner through the Asian Society of Pediatric Anesthesiologists. So stay tuned. Thank you.
So thank you, Dr. Usha Liponde, and to all of our speakers. Now I would like to open the floor for questions. I think we had answered some of them, but I would like to put them forward during our discussion. For Dr. Jin, I think there is an important question, which is IVC diameter is a good indicator for volume status, is it? Or decision for bolus fluid? How do you answer this? I think you.
Thank you for your question. The IVC diameter change during respiration may be a good indicator for volume status, especially in adult patients. But in pediatric patient, when the patient under mechanical ventilation, the intrathoracic pressure is quite increased. So after anesthesia or IVC diameter, not well changed during mechanical ventilation, respiratory cycle is very decreased. So I think that compared to self-respiration state, during mechanical ventilation, fluid responsiveness cannot well decided according to IVC diameter change. One thing to remember is that the pediatric patient in small patient, IVC diameter is quite small. So it might be difficult to the change of the diameter change during respiration might be difficult. So other parameter can be used for the fluid responsiveness in pediatric patient.
Thank you, Dr. Jintae. I think there is another question for you. He says that if POCUS has any role in deciding when to stop further resuscitation, what do you think? And
yeah, so this deciding stop CPR is a very difficult decision. So using cardiac echo, I don't think that it has a critical role because the POCUS role is the finding the cause and then the check the response to intervention.
So the deciding of CPR, stopping CPR might be very difficult to decide using echo findings. But we have some clue why patient ROSC doesn't occur from the echo findings.
Thank you, Dr. Jintaya. Joe?
Yeah, I think there is a question on the Q&A regarding a question from one of our Turkish colleagues regarding if ultrasound or POCUS lung can replace a chest X-ray, and what would be the medical legal consequences of using ultrasound alone for diagnosis. Perhaps Dr. Chaw can answer and other speakers can chime in.
Thanks for the question. Yeah. So basically, you could see that the picture that I show you is very selected video. Yeah, and the real life, you will going to face a lot of challenges to get all those nice video. Yeah, and all these come with practice, and in order to able to get the skill of getting a good image, and also we need credentialing. So the credentialing part to enable one to get the credentialing to perform this point of care ultrasound for you to be legally eligible. Yeah, not many centers are doing it. Yeah, so like My POCUS is doing it, and like back in Malaysia, Success is doing it. So we need to have a very good government body to monitor the skill before we embark ourselves to say that you are legally able to do it. Yeah, so it's very important. Yeah, okay, that's for me. Yeah, I've opened the floor for others to discuss. Yeah,
Dr.
Pradeep.
Yeah, in the neonatal intensive care unit now, in the last 5 years, we have collected our data about the newborns and the preterms and the X-rays and ultrasound. We could able to reduce almost 45% the X-rays because of the availability of bedside ultrasound, mainly for the respiratory distress syndrome, TTN, pneumothorax, effusion, and pneumonia. So yes, what Dr. Chor has said, we need accreditation, training, and legal component. But those training centers who are using day to day, they have definitely reduced the need of the X-rays in the intensive care unit.
Thank you, Dr. Paradeep. Any other suggestions from the speakers, from our speakers?
May I?
Yes.
You know, I'm just curious, Dr. Pradeep, may I ask you where exactly and how do you go about keeping the probe, and what is your exact protocol to do neonatal cranial ultrasounds?
Yeah, very important question. Very simple. The good part of the brain, that's the most easy part, is the anterior frontal. The advantage in the newborn is the anterior frontal is the biggest opening for us. So we can put basically as the coronal with the marker on the right side and go simple anterior to posterior. Immediately after 10 seconds, you shift to the sagittal and then actually go to the right and left. By these two methods, you get very easy views. At the same time, by keeping the probe in sagittal, you get nice anterior artery, and that's useful for Doppler. So immediately you screen from anterior to posterior, right to left in the both views, and you could able to identify these important bleeds, important abscess, what I showed you, and the Dopplers, which are important in the neonatology in day-to-day practice.
Thank you. That was very practical. Over to you, Sarpil.
And again, Dr. Paradeep, how accurate is POCUS for measuring intracranial pressure?
All right. So probably the one condition in the neonate, which is the very important from the POCUS point of view, is the bleed and then leading to the post-hemorrhagic hydrocephalus. So in that post-emergent hydrocephalus, which is important for us to monitor weekly measurement of the ventricles, because if the intracranial pressure goes up, that pressure goes up. Here we measure the anterior cerebral artery Doppler. The normal Doppler values are, that is RI values are 0.75 plus minus 0.01. When the value goes above 1, that is called absent flow, the pressures are high. You require tapping of the ventricles. Once your values are less than 0.8, you are in the safe zone. Definitely, that's the most important role for intracranial pressure in neonate. Dr. Chor can discuss about the pediatric intensive care unit. I'm not expert into that.
Yeah, thanks. To estimate the intracranial pressure by using point of care ultrasound is quite a challenge thing to do. So whatever we get from point of care ultrasound is basically looking at the circulation, the blood flow, whether the blood flow have any high impedance due to increased intracranial pressure. Because we could always remember that we are detecting the flow. The flow can be altered by increasing your systemic blood pressure to overcome the resistance. So we can estimate it whether the pressure is increasing in a certain degree and causing compromisations of the cerebral circulation, but using it as a surrogate number to say that this is how much value of the intracranial pressure, that is a job that is quite impossible. Yeah, thanks.
Thanks, Dr. Choriek. I think we have many questions to be answered. I would like our speakers to write their emails if it's okay for you, for our audience to ask you directly the questions we cannot answer during this webinar, since we are out of time now. So I'm very sorry to close this webinar. And there was a quiz sent to all our audiences. Please answer the questions, and the mails we will send you about the post-webinar survey. After you answer the post-webinar survey, the webinar survey, after it's mailed to you tomorrow, then your certificate of attendances will be sent back to you. Please, if due to our connection problems and if you miss some part of this webinar, you can watch the recording from our website or on Facebook or on YouTube. We want to remind you that ASPA is an empowering through education society. We are in ocean, and ASPA's mission is to foster the highest standard of pediatric anesthesia care in Asia. Hence, we seek your help to donate and help us in our cause. And we would like to invite you to our next webinar, which will be on the 3rd Sunday of January, about neonatal pain. Please just scan the QR code to register. It's free, but you have to register for it. And we would like you to join our ASPA meeting, which will be together with the Pediatric Anesthesia meeting of Malaysian Society of Pediatric Anesthesiologists during July 11th and 14th in Kuching, Borneo Convention Center. Abstract submission has started, and please join us. And we have to say goodbye to you all.